What has been the most rewarding aspect of your work in exercise oncology?
There's something about the cancer experience that is unique to any other chronic condition I've ever worked in, and to be able to give people parts of their life back is it's magic, man. It's what keeps me going. I'm in a position where I have a lab at a university where I get to train, the next generation of researchers coming through, and now I get to help shape people's perspective on what's important in research and get them excited. So seeing the next generation get excited, it's like, yeah, we're in safe hands, man. It's going to be good for years.
Yeah, that is incredible. All right, I'm here with Ciaran Fairman, who is an assistant professor of exercise science and the director of exercise oncology lab at the University of South Carolina. Ciaran's primary research focus is examining the impact of exercise, nutrition, and supplementation interventions during and after cancer treatments. And you are actually currently doing this to help me as I go through my cancer treatment and my cancer journey. We've been working together. We just started yesterday. You told me that I had awful form when squatting, but we're going to work on it. We're going to get better at that. But I really appreciate you being here. And I want to dive into really what is exercise oncology, because I had never heard about it before. I had gone through 7 months of treatment. Not once did anybody bring up the term exercise oncology. So what does that mean?
Yeah, and kind of backtrack, because that's kind of how we met. But the other role that I have is as chief scientific director of Inspired Exercise Medicine, where we're running clinical trials with Dr. Nakfor down here in Naples to see how exercise can become a medicine for cancer. And that's what's so inspiring about Dr. Nakfor in particular, but the field at large, right? So when you're saying I haven't heard about it, I've been doing this for 15 years and no one's heard about it.
Sure.
So when you, on the outside looking in, people are really confused of like, it seems so nuanced, like exercise and cancer, and like they're going through so much. Is it safe? Why should they even bother doing it? And when you get under the umbrella of that broad exercise oncology kind of term, it's fascinating, because you have to be so careful about how you design exercise around what type of cancer do you have, what stage of cancer do you have, what types of treatments do you get, how are those treatments sequenced, what's the dose, what's the combination. And so trying to put all those puzzle pieces together into understanding how we can use exercise to help people tolerate treatment better, recover from treatment more, and then potentially increase the effectiveness of treatment as well. And so my primary job as a researcher is to try and figure it out, do clinical trials, and partner with Dr. Nakfor at Inspire. We're also trying to kind of build that body of evidence contributing to that.
That's great. I mean, it sounds like this does exist, even though I've never heard much of it. And it sounds like it's something that is maybe a little newer. I mean, is this something that has been researched, or is this something that's brand new to the world of health? Relative
to research at large, it's brand spanking new. So the first study was like late 80s it was published. So it was probably like mid 80s it was conducted, and it was by a couple of researchers up at Ohio State University that looked at, really interestingly, to see if VO2 max, or like cardiovascular fitness, could be improved with people with breast cancer going through chemo. If I were to design that study now and propose that to a university or a hospital, you probably get a bit of resistance, but now we've got 30, 40 years of evidence to say that it's safe, so they'd give you the green light. In the 80s, people with heart disease were still kind of being told to rest. So like back then, it was revolutionary to be someone who has that vision to like, this can actually help people. They understand that people are getting deconditioned from treatments, so how can we use exercise as a tool? So when that was published, it was, we thought it was going to be game changing. Challenge is trying to generate research to replicate that was difficult. So for the next kind of 10 to 15 years, it was more so like looking at safety. Can people do this? Should they do it? And mostly centered around like broadly physical activity of like, can we help people not be bedridden? And then in the early 2000s, that's when stuff really started to take off, where people were looking at, can this really improve fitness on treatment? Can we look at different types and doses of exercise? And then the first guidelines for exercise and cancer was in 2010. They were published by the American College of Sports Medicine. And since then, it's exploded, where we're getting really specific with not just can we look at different types and doses, how can we make chemo, or how can we make exercise more effective, or make chemo more effective with exercise? How can we take someone with lung cancer who's had half a lung removed compared to someone with head and neck cancer who's losing 10, 15 pounds a week? That program's going to look different. So in the last 15 years, it's probably been the most exciting, where we're really starting to see people from all over the world start to go, what can exercise do as an adjuvant therapy for this patient population?
Was there a catalyst that caused this major interest on the medical world side to say, we need to be focusing on this, let's look at this? Or did that just happen organically?
Do you know what? I think it's a combination of a few factors. I think exercise physiologists, people who are trained in the physiology of exercise, it makes a lot of sense because, say, for example, like we know that mitochondrial dysfunction is very common with certain chemotherapy agents. They destroy mitochondria, so your energy is all over the place. You can't use as much oxygen, things like that. And so intuitively, if you want to repair mitochondria, exercise and cardiovascular exercise is one of the best ways you can do it. So as an exercise physiologist, it makes sense. And earlier, it was a lot of us driving the research, but we are still kind of the black sheep in the medical community, where you're trying to gain traction in a community that traditionally goes, well, you know, we can take these hard medicines and you know, help people. And then culturally, you're looking at another thing where, for right or wrong, people view the side effects of cancer treatment, a lot of people, not universally, people view the side effects of cancer treatment as collateral damage. I don't really care if you feel a little weaker because I've got the tumor out of your body and you're going to live longer. I don't care if you have a little bit of balance issues, you're living for the next 15, 20 years. And so we are trying to really reinforce the quality of the life in addition to just the quantity. And that's changing. The medical community at large is changing the focus on that. But I think that shift will be the thing that drives us forward, is trying to use exercise as a supportive care medicine.
Yeah, I mean, it makes perfect sense. You see exercise really being looked at, I think, in today's world. And I know, just being 26, I look at other people my age, my peers, and it seems as though a lot of us are recognizing we need to be exercising, we need to be eating better. And I really like the direction that that's going in. My question is, I've heard of exercise science before and not exercise oncology. Is there a difference? Do a lot of the premises overlay to one another, or is this very different in certain aspects?
Yes and no. So the way I think it'd be helpful to explain it. So my primary background is in performance science, or human performance. I got my master's in human performance and sports science, and I worked in, professional soccer with strength and conditioning, things like that. So I worked a lot at the upper end of elite performance, where you're looking with, competitive collegiate and professional athletes who are, in season, really competitive, demands on the body and a lot of stress. There's so much sports science centering around how do we tailor training programs to best manage stress, to optimize recovery, and then manage performance across like a 12-month season. And so there's so much on like, how do we monitor load? How do we adjust training load in accordance with stress? What are those stress markers? Whatever. So that's at one end of the spectrum, where you have to be really careful about how you prescribe and monitor the intensity, the type, the dose, the duration of exercise, and manage rest and manage nutrition. And then you take us Joe Schmoes who like hang about, whatever, we're not athletes. We generally will get most benefit out of most type of stuff, fine. Then you've got the other end of the spectrum in clinical populations, chronic disease, and in particular cancer. If there's any population that you need to very specifically care about how you prescribe exercise, the type, the dose, intensity, it would be someone who's going through chemo and radiation, and their side effects are all over the place, and malnutrition is involved, malabsorption of nutrients is involved. So it is the same principles. We're just applying it in different conditions and trying to use this science that exists and applying it into the clinical populations.
Well, it's great that there's a center that's focused on that, and it sounds like there may not be so many out there. So I just started my process, and just in one evening, I've found out so much about myself. I'm towards the end of my cancer journey, which I'm grateful for. But do you work with cancer patients at any part of their journey? Everything from start of their diagnosis to the end? And then is there a continuance as well?
Yeah. And that to me is what's fascinating. So again, I'll give you the parallel, right? So take a professional soccer team. You've got preseason. How fit can we get you going into season, knowing that you're going to pick up a few injuries? It's going to be a really stressful season. You know, you have to manage your conditioning to get through that. Then you've got the off season where you can kind of bounce back and recover and get ready for the next season. The same concept applies in oncology, where if preseason is for a team sport, we've got prehabilitation for oncology, meaning when you get a diagnosis, the most important thing we can do, one of the most important things we can do, is get you as fit as possible, because we know that fitness is going to buffer the side effects that you're going to experience. So, for example, someone with lung cancer who is going to get part of their lung removed, if you get one lung removed, you half your cardiovascular capacity. So can we, before you get that surgery, take a few weeks to try and increase your fitness as much as possible, to where now you've built the reserve in the other lung to compensate for getting that lung removed? So things like that is what we think about. Or even, say head and neck cancer, where we know the treatment for head and neck cancer is really rough. You might get surgery to the jaw, you're getting radiation every day to the head and neck region, and you're getting chemo once a week. People are losing weight at rates of 10 to 20 pounds a week. Can we increase your body mass in a few weeks before you go into that, to where we give you a reserve of mass that you can afford to lose in a way, because you're going to lose the weight no matter what. So that's the prehab. And then during treatment is the hardest thing for a few different reasons. The main one is, imagine if you didn't have cancer and I said, Jace, you're going to come to my gym for 6 months, you're going to train 3 days a week, and in 6 months you're going to look and feel the exact same. You'd be like, I'm not paying.
I'm not coming. Sorry.
Yeah.
I'm going to go work out on my own. Thanks.
Exactly. Yeah. I'll pay you for it. Yeah. So that's what is the most important. So in professional sports, you don't see the best sports scientists because injuries don't show. So it's hard to observe, if you didn't get injured, it's great. So in the same thing in oncology, if you don't do it, so it's less of a case, why should you? It's like what we know about cardiovascular conditioning. You go through certain treatments like chemo and hormone therapy, you lose a ton of muscle mass and strength. And because no one's talking about it, people are now in this aged condition after treatment. So we were chatting about this. The National Cancer Institute has this phenomenon called accelerated aging. And that refers to how much biological age happens in accordance with cancer treatments. Typically, that's about 10 years. So you age a decade biologically in months of treatment. So you go in, for prostate cancer, get chemo and hormone therapy as a 50-year-old, come out a year later looking, feeling like a 60-year-old. And then you're never told anything about,
what to do, exactly, right? How to reverse that.
So then the during treatment is, can we keep you looking and feeling like a 50-year-old? The challenge with during treatment is both physiologically and psychologically, there's so much going on. You've got all the acute side effects of treatments, nausea, sickness, all the things that people think about. Energy's all over the place. But then you've got mood, depression, anxiety, the financial toxicity of treatment, the sleep disruption that comes with that. So that's a lot to try and manage. So trying to keep people motivated, and also, because motivated is an insult, trying to keep them habitually exercising throughout it to where they look and feel the same is what the goal is. And then once you come out of treatment, you're in a great spot relatively. Like some of the acute side effects have kind of worn off. Now you're kind of ready to crack on. Like we don't necessarily have to manage, you got chemo yesterday, so we have to manage your nausea and whatever. It's more like some of that's gone. We can kind of start to build robustness to protect you from future injuries or a recurrence.
It makes perfect sense. And it is interesting, the doctors that are working with me currently, when I get to the end, they've done their part, but there isn't this pass off to, here's what you need to be doing now that you've beaten cancer. Here's what you need to be doing now that you're done. And although I'm not done with my journey, I'm grateful that I've met you and Dr. Nakfor, who's also doing my radiation. And you're sharing with me, hey, there's another side of this that is exercise that you need to do to rebuild your body. I mean, I was down 30 pounds almost, at the peak of when I was going through chemotherapy. And that's not even a lot. I'm lucky that I only lost 30 pounds. People lose way more than that. So I find it really interesting to hear that there is this one side where, hey, before you get into that world of treatment, we're going to do this. Here's what we're going to do during, and here's what we're going to do after. But what stuck out to me is the during part, because I think about when I was getting treatment, and if somebody came to me and said, we got to do an exercise, I don't know how I'd do it. Walk me through the process that you take with somebody coming in who's about to start treatment or who's in treatment currently.
So that's a really good point. And I think the main thing that we are trying to communicate is that not all exercise looks the same. So again, like so many of these principles have been borrowed from sports science. There's a concept called autoregulation, which is matching the stress of your training load to the stress of the individual and whatever they've going on. So in the context of an athlete, they've had 2 games in a week and it's towards the end of the season. Their training load or their internal load and stress is really high. So we need to chill out on the training. Just keep them fit. If I said to you, Jace, you're going to come in and do 8 exercises and you're going to do deadlifts, squats, like all that, you're going to go, you're out of your mind. But if I say, listen, I know that you have a low week this week, the stress of treatment's really high, you've got stuff going on in your life, just come out and hang out on the bike or whatever. The overarching principle is managing the psychology and the physiology. And the psychology is habitual activity takes over everything. If you can start to get to a point where the type and dose of exercises may be helping target different outcomes, great. But the first thing is that any activity is better than none. So what looks like stressful to you, so I'll reverse it. The other way to think about it is if I said, come in and do this, and you're like, that's way too intense, I'm not coming this week. And then next week I go, hey, you're going to come back in? No, it's like I'm still recovering from last week. Now it's 4 weeks gone. And yet then we're trying to get you back in. Whereas I'm like, come in, hang out on the bike, chat to me about what's going on. Building in those habits rather than like throwing more stress at you.
Sure.
Could be helpful.
Making it work, making it just do what you can. I mean, that's what some of my doctors did say. They didn't say it in the form of you need to be exercising. They said it in the form of if you can get out and get a walk in, do that. And it was presented in a way where that felt manageable, even though on some days going for that short walk was the hardest thing that I did in that day.
And sorry, to add to that, one of the things that we try to cultivate is the peer-to-peer support and the psychological aspect of social cohesion and peer support, meaning if you're training on your own and you're going to whatever gym on your own and no one knows you have cancer, people can experience cancer differently. Some people want to, don't want it to be their identity. Other people, it's really important to them. For the people that it's really important to them, it doesn't make sense for me to see you coming into LA Fitness or whatever and you're doing your thing and you're not interacting with anyone who knows what you're going through. Whereas when you're going through cancer treatment, so many of your appointments are filled with anxiety and fear and being like, is the cancer coming back? Is the treatment working? How am I going to pay for this? And then compare that to, yo, come on into the gym, hang out. You know what I mean? So-and-so also had non-Hodgkin's. They're, experiencing whatever that you only know. So I think that is also what's really important about building a supportive community in oncology as it relates to exercise and making sure that you've got something to look forward to too as well.
Right. That is great. There is that psychological aspect, that community component that I didn't even realize. I mean, everybody I saw at the facility in the evening last night, they're going through their own cancer journeys, and to be surrounded by that world where people know, hey, I can't do this workout because I'm struggling, and they're there to, say, hey, I'm going through this too. That's super important for going through cancer, and it's great that you have that community in there.
And I think it goes back to what you're saying, like, do you take people before or after or during treatment? One of the best things about that community is for the people who have finished their treatment, their hair's grown back and they look better. Because while it's ongoing, you can have a lot of support, but people forget pretty quickly that, like, yo, you had cancer a year ago. So
yes,
you look better and people think you're better, and no one has an idea of how much you're actually struggling, trying to deal with this new normal, trying to get back into life. And so one of the most powerful parts of that community is, like, it's sacred. You get to go and be like, yeah, they know, you know?
I love hearing you say that because that's exactly what I'm going through right now. I'm, as I said, getting toward the end of my treatment. They're expecting my next PET scan is going to be clear. And I'm growing my hair back. I have the energy, you know, I'm notorious for my eyebrows. So, you know, everyone sees the brows back. They're like,
yeah, pretty
he's
nice
back,
eyebrows.
man.
Yeah.
I appreciate it. I get them threaded. But, you know, people are looking at me and, you know, they want me to be done as much as I want to be done. And occasionally, you know, the fact that I am still going through this is put aside. So those areas where I can have that group that understands that this is not just going to be relevant right now, it's going to be relevant for a good while, probably when I'm done, because there's that recovery that's so important. And I really like that you guys do that. So talk to me a little bit more about, are you doing research at this facility as well? I mean, you're currently helping patients, but is there any research you can talk about that you're doing currently at Inspire Oncology? Is it, and this is called Inspire, I know Inspire Oncology, but it's Inspire Exercise?
Inspire Exercise Medicine, yeah.
Inspire Exercise Medicine, okay.
And listen, like it's Dr. Nakfor's brainchild. I have never met an oncologist as passionate as him about exercise as medicine.
He really is.
Yeah, like a large, so again, like a lot of large comprehensive cancer centers, it can exist. There can be exercise services. The single hardest thing about what we do is getting the medical community bought in, first of all. And then secondly, listen, like medicine is very time consuming on the clinician itself. So if you've got an oncologist who's seeing 40, 50 patients a day and they're talking about, here's what's going on with your tumor, here's the treatment plan, here's whatever, the last thing on their mind and the patient's mind is be like, and also, have you tried squatting? So it's to say that, like, even if people are passionate about it, it can still be difficult to promote it and facilitate people getting into a program, which I think is what separates Dr. Nakfor and Inspire, in that he put his like money where his mouth is. He was like, no, we're building this facility and this is going to be a part of your care. And so that's what's really inspiring to me about being a part of it. And how we kind of came to pass was his interest in developing more research, in understanding that quality of life is really important to a lot of people. Trying to get this as a standard of care in the country is going to take a mix of patient advocates, it's going to take a mix of policy, and then it's also going to take some strong evidence. And so one of the things we're particularly interested in is seeing if there are biomarkers in the blood that can predict how well people respond to exercise. And then if those biomarkers are also linked to treatment efficacy or you know, long-term progression or survival of disease. Research is very slow, and it could take a long time to generate that evidence. So we're kind of in this discovery phase of just seeing, like, of these biomarkers, does anything light up and is anything worth going after? And then ultimately the goal is to try and generate evidence that biologically exercise is changing your body, and that those biological changes can help increase the effectiveness of treatment or improve survival and longevity.
Sure. And I've seen, walking into my oncologist's office, some signs for Inspire Oncology. And on the signs, there are some, you know, hot flash facts. And I think one of them was exercise it either said it can reduce your risk or reduce something around cancer. Do you know what I'm talking about? Is there any, like, do you know the sign I'm referring to?
I know of a lot of the signs. I can't speak to a specific statistic.
Right.
The statistics are fairly overwhelming.
Sure.
In generally, if you maintain a healthy body weight, a relatively healthy body weight, and if you stay active, your risk of recurrence is, depending on the type of tumor you had, the stage of disease, so on, can be up to about half, which makes sense, right? Like, there are a lot of cancers, like 8 or so, that are linked directly to obesity and inactivity. And so if you've got someone who was previously inactive and has a lot of excess body weight, and we can help manage that body weight and increase activity levels, improve muscle mass, they're going to be way more robust to any future insult to their body. Their immune system is going to be better regulated. They're going to be able to attack things earlier. And so then you're kind of mixing both, like, the biology and physiology with, like, the practice. If you get someone into a completely different habit of approaching their life, of looking through healthful nutrition and body weight and activity, they also may be more prone or open to earlier screening for future disease or whatever. Because you kind of referenced it, but the other thing with having finished cancer that a lot of people without cancer don't understand or appreciate is how scary it is. I have this lump, I felt this pain, and that's the rest of your life. You're always like, what does this mean?
Yes.
And so you're hyper vigilant now. So this new normal that exists, you're always conscious. So that's a very long story to say that there are statistics generally to say increasing activity levels can reduce the risk of recurrence and improve survival. And that's ultimately what we're aiming for.
And I'm sure, I'll say this lightly, but I'm sure there is preventative aspects to that as well if you're exercising prior to cancer.
Yeah. Certainly in a lot of solid tumors and a lot of types of tumors that are associated with excess body weight, like endometrial is one, and breast cancer. Certain breast cancers can be linked to overweight and obesity, which is really important. The reason I kind of not pause is young, fit people get cancer. And so we have to find a balance between representing the evidence well and encouraging people to adopt healthy lifestyle behaviors, but also it's not magic either. And I think we have to be careful with our messaging and language around you should exercise because it's going to do this. And it's like, you've got marathoners who get cancer, you know what I mean? So balance.
Yeah, balance makes a lot of sense. And during my treatment, I did have a lot of doctors say, because you took care of your body prior to this, it's why you're not feeling this maybe as badly, or why there was a scenario where the tumors in my mediastinal mass was causing fluid to build up around my heart. And there was about 250 milliliters of fluid when they had to urgently remove it.
Wow.
And I saw my oncologist a week after, and he shared with me, if you weren't as active and your heart wasn't in that good of shape, there was a good chance that you could have died in that moment. And I just had this big eureka moment of, you take care of your body, it takes care of you when you need it most. And that's something that will definitely stay with me. And it's very important. So for those that are coming in that maybe they're older or don't quite have the history of exercising, what kind of factors do you take into consideration when they're coming into the clinic for the first time?
That is my favorite part about what we do, because you get a lot of people, who are 50, 60, 70, who have previously not exercised. And so much of the benefit of what we do is centered around muscle mass and strength and physical function that ends up meaning you have to do a lot of strength training. So people are like, what are you doing to me? And so we spoke about this yesterday, but we have a very clear assessment protocol where we look at what is your cardiovascular fitness like, what is your balance like, what is your physical function, using standard battery tests. Like if I say the timed up and go or the 6-minute walk test or the short physical performance battery, people in the community will know that they're kind of gold star physical function assessments for older adults and clinical populations. And then there's certain thresholds within those tests that determine, are you, at the upper end of ceiling of function, you're pretty good, or are you in a frail condition, or you're a lower function condition where now we need to tailor the program differently. So we have a tiered system whereby, based on the results of those assessments, we kind of have a general indication of your physical function, and then we pair that with your previous history of activity, along with your goals and some psychological assessments to kind of determine what level of class that might be more suitable for you. All levels of programming generally will incorporate some degree of balance training, strength and power development. Some of it is tailored towards building muscle mass, and then there's some conditioning involved. But that looks completely different. So, for example, at the higher end, you've got people who are marathoners or ultra runners or whatever, and they come in, they're fine. You can throw the kitchen sink at them. Or they've got a really high degree of proficiency in training, so we don't need as much coaching. Some of the people who are at the lower end of conditioning, they can't get out of a chair. So that's the program. Let's help you get out of a chair. And the thing that kills me is cardiovascular exercise has been the king for years. It's been great at people advocating for heart health, and it's really, really good. What happens is there's been an overemphasis on cardiovascular health at the expense of physical conditioning. And what puts people in assisted living is They can't get out of their car with their groceries. They can't walk up and down the stairs. Someone rings the doorbell and the cat runs out and they can't catch themselves from falling and stand back up. All of that is physical conditioning and muscular strength and function. And so again, when you're coming down to like someone who's at the lower end of conditioning, if you can build some resilience and robustness in their body, you give them their life back and you stop them progressing into accelerated or assisted living and stuff like that. So I think that's what's my favorite part about it, is the people who are the most deconditioned and probably the most fearful are the ones that stand to benefit the most.
Sure. That makes perfect sense. Have you seen scenarios like that where somebody came in and they couldn't get out of a chair and then you help them? And
you get emotional because it's also, it's magic with how quick it happens. And now again, it's not universal. There's a lot of factors that influence it. But for the people that do get these type of benefits, like most of our programs are kind of in the range of like, we run them in like 3-month batches and then you have the option to renew. But within 3 months, people come in with walkers, lose their walkers. And one of the measures we have is gait speed. So how quickly your normal pace is. And that gait speed, basically when people start to do that like shuffle, that risk of falling is pretty high. So if we can give them back that single stance where they're taking larger steps and quicker steps, it's magic. And again, like those are the outcomes that are important to us. It's what you hear when they say, I can go out and play with my grandkids again. I went fishing with my son and I wasn't like, it's magic.
Yeah. And pair that again with just, you're not just doing this as somebody who walked in and they were perfectly healthy. You're walking in with somebody who was potentially just sitting for, I was in a hospital bed or sitting on my couch or laying in my bed for 7 months.
Yeah.
And I can't even imagine, like you said, it ages you, could be a decade. So just to hear that they're able to then leave with a new ability to get back to life.
And you
incredible.
know what, there's a psychological component in there as well, referencing like, if you didn't go to a specific facility like this, right? You go to Planet Fitness, you get a personal trainer there and they give you like, here's your machines. So you're going to do the chest press, the leg extension, whatever. That works for an extended period of time, but you don't have the social support. You don't have anyone who knows your cancer experience. And what happens when you leave that gym and go to a different gym and the leg press looks different? You haven't been told how to actually move your body. You haven't actually been told how exercise works and how you can build in critical thinking for yourself. And so our approach is movement based. Again, it stems from sports science. It's nothing inherently novel in that world, but bringing it into the clinical population it is. So the squat pattern, the hinge pattern, horizontal push, horizontal pull, vertical push, vertical pull. These are things that you do every single day. And so it doesn't make sense to shove you in a leg extension machine and you're not actually moving your body well. So again, coming back to your person who's deconditioned, who hasn't exercised before, throughout that 12 weeks, we're also building in your understanding of what this means, how to move your body, so that if you leave us and go to another gym, no sweat. You already know how to move your body. And so you're not as reliant on a single exercise or machine or device.
Right. Teach a man to fish.
Exactly.
Mentality.
Exactly.
What are some of the biggest gaps right now in the current understanding of exercise oncology? And where within that do you see the most urgent need for further research?
So the clearest gap is the more rare types of cancers or ones that we don't have as much access to. So the most robust body of evidence is in breast because it's so common. There's a lot of really great awareness around breast cancer, and relative to some other treatments, particularly for say early stage cancer, the treatment is a little bit more tolerable to where people can maybe withstand, the added stress of an exercise program during treatment. So you got a lot of really cool evidence in breast, prostate, lung, colon. You take advanced pancreatic cancer, we have no idea. You take stage 4 head and neck cancer that's metastasized, no idea. And so we're trying to generate evidence in more rare forms of cancer to understand what can it do, what are the limits of it, is there any circumstance where it might be, harmful to do it? The challenge to that is because these cancers are so less common, it's way harder to do the research to get them. So, without knowing the size of Naples, if you were to try and do a catchment of people with breast cancer here, it's the most common breast cancer. Or it's the most common type of cancer. So you're going to get loads of people. if I wanted to study, myeloid sarcoma, how many of them exist? So you have to do these like large multi-site studies all over the country, if not the world, and to generate like sufficient evidence where you have like hundreds or more people. That's taken like, where you might pull off a study in breast cancer in 3-4 years, the sarcomas one taking you 10 years to get the same volume of patients.
Yeah, that makes a lot of sense. And I just want to clarify too, we've been talking a lot about exercise oncology, but this is not in replacement of traditional medicine.
Yes,
this is supplemental alongside.
Yeah.
And so my curiosity with that is, and I'm aware of this, your facility also studies and is aware of how exercise plays a role in, and you mentioned this a little earlier, but the effectiveness or maybe effectiveness is the word, to chemotherapy and radiation. Could you go into more detail about how exercise plays a role within those treatments?
Absolutely. And there's a couple of fairly clear examples of this. So one of which is there's been a really strong body of evidence that shows how much muscle mass you have going into chemotherapy can impact how much toxicity you have from that chemotherapy, and may also influence the dosing of it. So, right, broadly, you're getting chemotherapy and you're going to get some side effects. Those side effects are way too much for you to handle. You get a little bit more sick and you're like, yo, I can't come back for my next chemo. And they're like, right, well, let's kick it back a few weeks, let you recover. Or they'll go, okay, maybe that dose is way too high, let's drop your dose. So when they kick it back a little bit, that's called a dose delay. And when they drop the dose, that's called a dose reduction. So both how quickly you can get your treatment and according to schedule and how much of it you can tolerate, both are linked to how effective the treatment is. And so we're still trying to understand like what specifically the mechanism is, but we think that the larger body of muscle mass you have, the more you can metabolize and clear the chemo better, and you can tolerate it, you're more robust, your immune system's better, so on and so forth. And so that your acute side effects, your nausea isn't as bad, maybe your sleep is a little bit better, you can tolerate the acute side effects more, which means maybe you don't need those dose delays, or maybe you can handle a little higher dose than you would otherwise, to where ultimately the treatment is going to be a little bit more effective. Now, so much of that evidence comes from animal research right now. It's all preclinical. There are 4, to my knowledge, ongoing randomized controlled trials looking at, can we get people to exercise? Can we improve their muscle mass? And will that lead to better clinical outcomes? So there's 4 major investigators across the country in the US that are doing these trials. And in the next few years, we're going to see how that plays out.
That's interesting. I had a dose-adjusted Epoch R. So every time I'd go in, they would look at my blood work and say, okay, we're going to either increase your level. They did it by levels, or they wouldn't. And I always go in with it as a challenge. Like, I want a higher level. And they're like, that's not really how it works.
Yeah.
You don't want that. But they said that the guy got up to level 5 or something at the highest. But anyways, it's interesting to know that stuff. I mean, maybe if I knew that muscle mass played a role in that, I would have, prior to going in, focused a little bit more on building muscle. But I'm fortunate that I got through it like I did. What factors are most important to consider when designing programs for cancer patients?
Yeah. So it's fascinating to me. Like it's just a jigsaw. And I think it's probably what most appeals to me about the field. So the type of tumor you have, whether that's solid or liquid, where it's located in the body, will all, and the stage of disease. So like stage 1 solid tumor, say breast, you might get surgery and probably won't get any other treatments. Whereas breast cancer, stage 3, stage 4, you might get chemo, hormone therapy, radiation, and surgery. So they're 2 entirely different people. Then, so the type and the stage and how aggressive it is will influence what types of treatments you get. So not just as far as like, are you getting radiation versus chemo, but different types of chemotherapies can have different impacts on the body. So there's a group of chemotherapies called taxane-based chemotherapies, and they're known to be really damaging to the nervous system, which means that peripheral neuropathy, so like changes, numbness and tingling in your extremities and balance issues and things like that are very common with taxane-based chemo. Whereas say anthracycline-based chemo, like something like doxorubicin, known to be like
The red devil.
Yeah. So we talked about this where it can have a lot of damage to the cardiovascular system. So inherently already you're seeing same type of cancer, same stage, getting different types of treatment, whatever. You've got someone who's got balance issues and someone who's got heart issues. So program starts to change. And then are you getting surgery first or are you getting chemo first? And are you getting chemo alone? Are you getting chemo with radiation? And then you're getting both of those with hormone therapy, or is all that so that combination sequence dose duration, we know generally the side effects are a combination of how long you get the treatment and how high each individual dose is. So the higher the dose and the longer you're getting, the worse your side effects are going to be, which is then influencing like not just how we can manage the stress of that, but how much of this side effect we got to deal with. So type of cancer, stage of cancer, how aggressive it is, the treatment characteristics. Then we talked about stage 4. One of the major things that's involved there is metastasize. So the cancer has spread to another part of the body. In relation to exercise, one of the biggest things that we're concerned about is bone metastases. So if a cancer has latched onto parts of your bone throughout your body, there's different types of bone metastases, meaning some types of lesions can latch onto your bone and make you grow bone. And then some types of lesions can latch to other types of cells in your bone that may basically just carve away your bone and make the bone really fragile.
Terrifying.
And so then you go to a gym without supervision. So
right.
we have to think about like, do you have osteoblastic lesions? Do you have osteolytic lesions? Blastic is hardening and not a pain. Lytic is very porous, high fracture risk. So you have to be very careful about how you're moving and stuff like that. So type of cancer, stage of disease, treatment characteristics, are there metastases, the psychology of it. How is your state psychology? How are you generally as a person? And then your trait psychology. How is your anxiety and depression changing across time? How is your attitude towards exercise and all the rest of it? So that's the cancer characteristics. Then, do you also have diabetes? Do you also have COPD? Do you have knee osteoarthritis? You had knee surgery back in the 70s, whatever. So all the other stuff that comes with being a human being, all of that comes together where we try to figure out like, what do we do?
It's a full picture.
Yeah.
And that's great that it's a full picture. And that's another good part. I mean, every time I go to the doctor's office, and I think this is common practice now, you get an emotional wellness intake. And I know it to be fact, exercise helps with at least my emotional health. I feel better. I'm able to not be as stressed. So you have less stress, less inflammation, your treatment works better. It all really makes sense. You have such a passion for this, like, and you know what you're talking about, thankfully, because I'm working with you. I'm glad you know what you're talking about. What brought you into the world of, I'm sure it started with exercise science, but maybe I'm wrong. Did it go right into exercise oncology? How did you get here? Yeah.
So I was an idiot my whole life. Like I whatever, failed high school, all that mess. But I thought I was going to play soccer and realized I was useless. And the only thing that made sense to me in college in America, so I came over on soccer scholarship and was like failing all sorts of classes because gen ed, whatever. Taking classes, like as an Irishman coming to this country, I was taking like geography and French and all this mess. Couldn't care less. Only cared about playing soccer and wasn't doing great. And then I had this exercise physiology professor in college that blew my mind. And he was talking about like how enzymes change when you warm up. And then he would come and watch me play soccer. And then he would come back into class and be like, why were you doing that move? And what's happening to your body? Blew my mind. And at the time I was fully convinced, like, I want to be sports science. I want to go and see how we can change the body through activity and exercise to improve performance. And then my ma got breast cancer my sophomore year of college and I wasn't able to go home for it. So I was kind of listening to everything that was going on with her over the phone and hearing everything that she was going through. She was losing muscle mass. She was getting weaker. Energy wasn't as great. Fitness was declining. Strength was declining. All these negative side effects of exercise were kind of like what I was learning about the negative effects of cancer treatments are what I was learning about what the positive effects of exercise are. And so I was really fortunate that this professor, Jason Crandall's his name, he took a personal interest in me and that experience, and he flew me out to my first national conference of exercise physiology. There was a group out in Colorado who were doing some research into space. He talked to them, and basically as a third year college student, helped me set up a cancer rehab clinic in the town, born purely out of passion.
Wow.
He was amazing. And that changed the course of my career and my life, and been doing it ever since.
He's not the only person that you've, inspired or connected with. How did you end up getting connected with Dr. Bruce Nackfor?
I think to what you're saying, man, I'm really drawn to people who are passionate about this. Like my passion is like, it's such a burning desire that it's not going to change, but it's enhanced when I'm around someone who also has it, you know what I mean? And again, what's unique about him is that he is in oncology. He's a radiation oncologist by background. And so to see someone like that so passionate about exercise medicine is really refreshing. And so I just love being able to have conversation with him, hear how he thinks about it. Because as passionate as I am, like, I'm just the idiot who exercises. Whereas he is the one who's like, yeah, let's change practice. How do I help it?
You don't give yourself enough credit. I don't know if you've been listening to yourself, but you seem to know a good deal about this stuff. Well, with this expertise, and you're going to continue this journey, where do you see exercise oncology going over the next decade?
So the best case scenario, and there's a lot of really great people trying to drive policy change on this, is that we mirror cardiac rehab, which is to say, in the US, it is covered by insurance for you to go through exercise oncology rehab or whatever. So there's a few countries. So Australia have a model whereby exercise physiology in Australia is held at the same level of respect as physical therapy is here.
Okay.
So it's a credentialed profession, and they've got really great like reimbursement models. When you get diagnosed with cancer in Australia, they get 5 free sessions with an exercise physiologist, whereas here, like, it's a lot of insurance. In Germany, if you get diagnosed with cancer, you get 50.
Wow.
50 free sessions training with an exercise physiologist. So if you're asking me what the goal is like, for the financial toxicity of cancer treatments in this country kills people. So the last thing, as passionate as I am, the last thing that I understand we need to do is go and also, pay a bunch of money for this. So can we make sure the treatment that we know is as effective as it is to enhance people's lives going through and after treatment, is that accessible to as many people as possible?
Unfortunately, I hear this answer from a lot of people who have solutions, and I'm sure the world would love to get them all available, but it's good that they're growing and they're evolving, and I do believe they'll get there at a certain point. What has been the most rewarding aspect of your work in exercise oncology?
Man, you were saying I was disparaging, but like I truly believe this, man. Like, I just got so lucky with being able to find something that I enjoy doing, and there's something about the cancer experience that is unique to any other chronic condition I've ever worked in, and the destruction it plays on people's lives and the lives around them, and to be able to give people parts of their life back is it's magic, man. It's what keeps me going. And now I just feel so fortunate. I'm in a position where I have a lab at a university where I get to train, the next generation of researchers coming through. It's incredible. Also, like, they probably shouldn't trust me as much as they do. But being able to have this philosophy that it was just come from a burning desire to help people. And now I get to help shape people's perspective on what's important in research and get them excited. So seeing the next generation get excited, it's like, yeah, we're in safe hands, man. It's going to be good for years.
Yeah, that is incredible. What advice would you give to cancer patients and survivors who want to incorporate exercise into their treatment or recovery?
It's going to look different for everyone, and it's going to look different for you on any single day. So it's not that there's this gold standard, you need to hit this. Any activity is going to be better than none. If you can get to the point where, we can start to zero on the type and dose, sure. But we know that the most benefit stands from going from not active to active. Then there's some nuances down the line. And then find a good support system that can help you maintain that activity as long as you can.
What message would you want to leave with our listeners about the importance of exercise in the fight against cancer?
There's nothing that is more powerful that's in your control.
I love it. Ciaran, you've been awesome in sharing all this information. And as a cancer patient currently, having information gives me power. It makes me feel like I have options. And even if somebody doesn't have cancer, just knowing there's solutions, knowing there's options out there, it's the best thing that can happen. So I appreciate you so much for coming on and sitting and talking with me, and just, you've made a big difference in my life. I'm really excited to keep going through the process. And thanks for helping everybody to stack the odds in their favor today.
I appreciate it, man. We'll wait to see, like, don't talk about it positively until you finish the program. The next episode, you might be like, this fella's not doing anything.
I broke my leg.
Nah, man, pleasure. Yeah.
Cool. Thanks so much.